Thank you. Oh, the raffle winner. Raffle winner. We had 30 seconds for the raffle. Dr. Place.
All right, round two. So again, I just want to reiterate how data-driven NIHC is and also the whole infant mortality initiative. So I really, really appreciate all of you for sending in your responses. I think just in the past 5 to 10 minutes, we got like at least 80 new responses. And given that there's about like 100 people in here, it's like 80% response rate. That's very, very high, honestly. So thank you all for all your work and sending in those responses, whether it's for infant mortality or for the gas gift card, you know. All right. 155. Just give me 1 second while I pull up the raffle. All right. So our winner for this round is Aubrey Parks. Congratulations. Come on up. You get $50 gas gift card. And just a quick reminder, so at the end of the survey form, you get to fill up your name and your email. That's where you kind of put your entry into the raffle pool. So make sure to fill your name in if you want to participate. Thank you.
All right, everybody, welcome back. Continuing with our event, I would like to introduce Dr. Jean Marie Place. Dr. Place is a maternal and child health care researcher. She's taught at Ball State University since 2014. Some of her qualitative research topics include perinatal adverse experiences, postpartum depression, sexual violence, and infant mortality, among other areas. She's also collaborated her research with other international organizations such as the World Bank, Inter-American Development Bank, UNICEF, and the National Institute of Public Health in Mexico City. Dr. Place co-leads the Addiction Coalition of Delaware County as well.
Well, thank you so much. It's such a pleasure to be here and to work with Liliana. She and I have worked together for over 10 years so it's just a pleasure to be here with all of you today. So similar to the quantitative research, I have worked with this wonderful team to conduct some qualitative research, both among healthcare providers in the Elkhart area, as well as members of the Hispanic community. So among the providers, we did about an hour in-depth interviews. And then among the community members, we did focus groups where we got together in a larger group and discussed some of these topics. I was impressed with the data. It's robust data, it's rich data, there was plenty to analyze, and we got a lot of interesting insights related to awareness, to knowledge, to attitudes, barriers, needs, and gaps. So I'm really excited to be here today and share what our Hispanic community members and neighbors talked about these issues, and it's really a pleasure to be able to elevate their voices. So as I go through the results, I want to point out that the C's, you can sort of see the C up there, that refers to being a theme that was really salient and important among community members. And if there is a P present, that means that the theme was also very common among providers as well. But in this theme, the community members really focused on this. And this is a theme relating to the importance of just talking about the issue, of really expanding and elaborating on what the term infant mortality is. So the majority of focus group participants did not know the definition of infant mortality, which is the number of babies who die before their first birthday. This refers to the idea that infant mortality is a little bit like a black box among lay members of the public. Now, perhaps those of us here today are familiar with this term, but it's important to remember among lay members of the public, they're not as familiar with this term. It reminds me of some of the first research Liliana and I did together about 8 years ago, where one of the results was that when we share the word infant mortality, the understanding among lay members of the public is about child abuse. So it's really careful for us to always include the definition of infant mortality so it doesn't get confused with other terms. So let's see. I don't know. Is there a way to scroll down on my notes? Is there a way to scroll down on my notes? Thank you so much. So this is so important to talk about what the definition of infant mortality is, because then we can talk about the power that the members of the Hispanic community and all of us in this room have to change behaviors. In addition, a lot of people talked about knowing someone. There's personal experience with people who have lost a baby. So infant mortality, while they may not know the definition, it's part of their lives. They have lived this experience. And so let's read a few quotes about this. A community member said, "I think that while the process is going on in a place like a clinic, there should be information on infant mortality." She said that the word is actually new to her. She said, "I recently looked at it and I read it and I didn't understand it. Mortality, it sounds like death, doesn't it?" So there's some information that needs to be shared about this. Another community member said, "We all have some ignorance, but if you don't explain it to us and if you don't let us know what it really is, if you don't give us those resources, if you're not explaining it, how do we know?" So this reminds me of the bus, right? And how important this bus is to explaining what infant mortality is and making it a more visible part of our community. Not only infant mortality, but infant vitality and helping infants to grow. So this next theme, both providers and community members really recognized how important physical health is to a pregnancy, particularly these concepts of maternal age and weight. So these were perceived to play really predominant roles in poor birth outcomes. But that said, both women and men felt like they didn't understand what to do with that information. Did they have the self-efficacy or the knowledge to know what to do with that? How do they take care of these chronic health conditions? How do they address obesity? They also talked about that while they know physical health is important, they struggle to access the medical system that can help them with this. So what they end up doing instead, they talked about, is accessing guidance from the internet. This refers back to one of Dr. Johnson's results, right, of using Facebook to help provide accurate information, because that's what they're accessing in some cases, family members and friends. And some of the advice they're getting is contrary to medical recommendations. They talked about not necessarily understanding or knowing how to follow providers' instructions. So they might have a chronic health condition, but they don't understand the full picture. What does gestational diabetes really mean? What is it really doing in my body? And why is it so important in my diet? Other concerns are with what preeclampsia is, for example. So, but they do understand that chronic health conditions and advanced maternal age is going to have an impact on the pocketbook, right? The more that you have these conditions, the more they may ask you to attend visits at the health clinic, and the more expensive it could be. So, we need, as providers, to really look for ways that we can ensure understanding of these health issues among the patient base. And that can be through a talk-back method that's evidence-based. That can be through motivational interviewing, but that's a really important part. So let's look at some of these quotes. These quotes on this slide focus on their understanding of the older that you get, that can be a high-risk category, and that more appointments and more medical exams are necessary. But they also believe that the younger the mother is, community members said the stronger she is, right? That's the younger she is, the stronger she is. And you can see that in the rates of teenage pregnancy that Dr. Weaver talked about, that it's significantly higher among Hispanics than in other race and ethnic groups. So providers felt like when we bring up teen pregnancy, we shouldn't be limited to the frame that they're younger and they're healthier. That's an oversimplification, right? We need to consider additional factors, such as that they may be single mothers. They might not have the support that they need. They're facing other risk factors that could put their pregnancy at risk. Okay, so this one talks about that in addition to the physical health of the mother, the emotional status of the parent affects pregnancy, and this matters significantly. So the stress that many women and men endure can affect health. There was one member of the focus group who said that stress means taking it out on the baby. Finances are a significant cause of stress, along with immigration and the lack of social support. I remember that someone in the interview said, it can feel impossible to take care of children when you also have to manage the household, spend extremely long hours at your job. They're not offered flexible time off for sickness. They can't get time off for doctor's appointments or childcare, and they lack the support of family and friends. That does feel pretty impossible. Providers, too, recognized the stressful circumstances of their clients. They talked about, they might not have an ID, and when you go to check in, they want an ID at the health clinics. They talked about the worry of partners driving without a driver's license and how that could exacerbate some immigration concerns. Okay, they also talked about that after childbirth, concerns like postpartum depression, failure to bond with the child, being a teen mother and feeling like there's community stigma around that, all of that can be really tough emotionally. All right, so let's talk though about this slide, which is that when we were doing the interviews, a lot of the community members wanted to talk about the postpartum period because that was a period that they perceived to have more control over. They weren't necessarily beholden to all of the visits during prenatal care, and they could kind of finally break away from that and exert more control over their lives and their family than what they felt like they had control over in the prenatal period, which is more dependent on the bureaucracy of the healthcare system. So providers also recognized that Hispanic moms are incredible, right? That they have high rates of breastfeeding. They try to do that even at workplaces, although that can be difficult because some workplaces won't allow them to pump, so their milk supply decreases. Providers talked about how important it was to help provide support for bills, because it can often be after pregnancy that the bills start accumulating for the care that they received during prenatal care. And that accumulation of bills can prevent them from coming to the postpartum appointments because you feel like, man, I'm drowning in bills. They also talked, and you'll see in the quotes up here, if you scan the quotes, that they talked a lot about the importance of la cuarentena. So this is a postpartum 40-day period in Hispanic cultures when new moms rest, recover, bond with their babies, and they may abstain from sexual intercourse, they focus on healing, and other women in their circles and networks care for them, ideally, right? And how hard that can be in the United States culture where we have a 2-week visit with your baby, so you need to pack up even in the dead of winter and take your baby into care, or you might need to go back to work for financial reasons or lack of benefits. And that discrepancy of wanting to practice a traditional practice after delivery and how difficult it can be. So this next slide is really important because we know safe sleep matters. In Dr. Weaver's presentation, it was the big yellow boxes, I think, that talked about the percentage of babies who die due to unsafe sleep environments. And there is confusion around this in the Hispanic community because we're talking about babies should sleep on their back, but we're also talking about them having tummy time. And so there needs to be some clarity around that. We need to also talk about temperature control, that we're telling parents often to just put them in a onesie without any other blankets and they'll be fine. And there is some concern among Hispanic members that they could get cold. There's concern among providers that when they see babies really heavily wrapped up, that's a concern. So we can look more at temperature control and how to communicate around that. There's also concern that we may be providing pack-and-plays or safe sleep boxes or cribs, but in some housing situations, there is simply no space for that kind of extra apparatus. Many Hispanic immigrants sleep in crowded rooms that could be dangerous. It elevates the risk of unsafe sleep practices. And some of those unsafe sleep practices may be supported by generational or cultural traditions that are the default mode of perhaps co-sleeping with a child. And so to be really cognitively conscious and respectful of those cultural beliefs while also trying to communicate about what the evidence says about co-sleeping and other practices. So let's go to the next slide. So this one is talking about barriers that have now been identified. And providers disagreed a little bit on this one. Some providers said that there's not a shortage of providers in Elkhart County, but other providers argued that there are shortages in primary care providers, ones that will take new patients, or the availability of providers who will do delivery. They talked about the shortage of midwives particularly. But the community members said that they did recognize that there were pregnancy groups available and they appreciated that. But overall, looking at both community members and providers, a concern was that OBs are generally booked for many weeks, leading some women to not be able to receive care until their second trimester. I was struck by Dr. Weaver's comment that just one prenatal care visit in that early period can be preventative for infant mortality and some of these poor birth outcomes. Providers also highlighted that some prenatal care centers are not operating at all due to lack of providers, which then makes patients go into other facilities farther away, which contributes to these concerns around transportation. All right, they did I do want to bring this up as well. This was important, that some community members expressed a lot of stress because providers rotate. You might not have the same provider for prenatal care as you do for delivery. And that was a real cause of stress, especially in the final weeks before delivery. Women shared stories about having to go to the ER in the final weeks for pregnancy because they were confused around where they should actually go for care. So let's read a quote from the healthcare provider in this case. She says, referring a patient to Goshen OB-GYN advisors in week 32 is a toll for a patient. It is starting over at a crucial point in the pregnancy. Yes, they have great providers, but the patient is not going to have the same confidence in making phone calls to ask questions in Spanish. The billing process is going to be different and very limited on discounts. Maybe there's transportation issues that become a bigger issue with the distance, among other things. All of this adds up and increases stressful circumstances that are going to affect the health of the expectant mother. So in line with that, let's talk about language and cultural barriers. So this is an interesting one because we need more Spanish-speaking providers. When we don't have Spanish-speaking providers, miscommunications happen. And importantly, to your comment earlier, it's a barrier to develop trust, right? If we can't speak in our native languages. It increases the lack of confidence in the system to adequately address medical concerns, and they might not feel comfortable asking for clarification. You know, as a woman who has a PhD, I still get nervous with providers asking questions. And I know this. And so I think about how difficult it must be for a new immigrant, unfamiliar with the US system, and in a different language to ask questions. That's really challenging. All right, so another thing, and I'm just going to kind of list out some differences between the US healthcare system and the healthcare system in an immigrant's country of origin, because these differences can feel very vast, very overwhelming, and very hard to understand. So the differences include: how do you schedule an appointment? How do you access pharmaceuticals? How do you access contraception, particularly long-acting contraception? What happens if your care is delayed? How do you receive results? Do you know how to access the patient portal? What about referrals? And how does billing work? All of this can make patients feel frustrated and discarded, like they're not being treated respectfully. So they're also used to having pretty long consultations with a doctor in their countries of origin. And they're interested in getting the results of their lab work and having a hard copy of their results. They also think that generally you can get contraception over the counter in their countries of origin. That includes the pill, and unable to do that here. They're confused about why they have to show an ID to pick up medications or to check into appointments. And then, of course, as we've talked about, the inconsistencies with how OBs refer and transfer women. Another big one that a lot of women talked about was that here in the States are only 3 ultrasounds allowed, and roughly, and in their countries of origin, they can get almost unlimited access to ultrasounds at a very reasonable cost. And so that's important for them because they want to be able to bond with their babies, and it makes them feel assured that their baby is doing well. So finally, there's a lot of concern with legal documentation, what's being asked for them to provide in terms of their social security number, work authorization. We can talk about that some unfriendly treatment that they feel like they're receiving, and this just may be cultural differences in how we saludar and how we interact with each other, but it can leave some women not wanting to return to get care or to avoid seeking care. If you think also about some of the trauma that immigrants have suffered as they've arrived in the United States, some of the very difficult journeys, the US healthcare system can be somewhat triggering, the loud noises or the chaos in the waiting room, that can be stressful as well, particularly for teenagers. We would be remiss if we didn't talk about the federal executive orders in 2025 regarding immigration issues and the noticeable fear that we're seeing among Hispanics, leading some of them to avoid seeking care. The quotes on the other slide talked about how some women have chosen to give birth at home in order to avoid going to the doctor. And finally, I only have a few minutes, and so I'm going to go a little bit faster in order to allow questions. But these financial concerns are just so salient, so important to address, whether we can provide vouchers for patients, whether we can advertise how to get discounts for these kind of cares. Indiana has limited Medicaid coverage for undocumented immigrants, while other states, we can acknowledge, provide full coverage. So emergency Medicaid, which is Package E, from what I understand, covers only the delivery and excludes prenatal care. Package B does cover prenatal care, but does not cover contraception after birth. So these kind of gaps can make it pretty confusing and lead to frustration in billing. All right, and these quotes, if you can kind of scan them briefly, they're talking about not going to appointments anymore because they're scared of the bills, arriving late to an appointment and then getting charged extra. $50 is a pretty hefty penalty for someone who is low income, etc. Alrighty, and this one I think is the one that we end on, which is there's a massive need for educational programming on the topics of reproductive health, sex education, that would be medically accurate and comprehensive, and preconception health. They want this. We did not have a question in there kind of prompting them to mention this. This was voluntarily shared among members, the need for appropriate sex education. But they certainly did appreciate help from WIC, the Women's Care Center, Healthy Babies, and they talked about tapping into those resources when they could. I would love to just leave the next couple of minutes to see if some community members in the audience or members from our healthcare systems can sort of comment on these results and maybe share some stories that help to emphasize these results.
You want to go, friend? Maybe take this. Okay.
I was asked to come speak on some programs that Maple City Healthcare Center offers. Not just an eager member to come up here and steal the microphone. So, my name is Kelly Fry Martin. I'm a registered nurse. I work as a pregnancy care coordinator at Maple City Healthcare Center, and just wanted to highlight a few of the things that Maple City is doing to try to reduce some of these barriers and make care more accessible for women that fit these things that we've been talking about today. There are many things. I want to highlight two that I feel are very important. I'll start just with a few of the other programs and kind of go quickly over those, and then I'll end with the two that I want to highlight. One is that Maple City prioritizes hiring bilingual staff, staff members who speak English, and then also if they can speak another language. Spanish is a huge one, either Russian or Haitian Creole as well. If we can hire staff who are bilingual, that really, really reduces that barrier because the provider can speak in the same language as a patient, reducing the need for an interpreter. The other thing, having an integrated healthcare model where you can hopefully tie in that whole continuity of care. So patients are established with a family practitioner, they become pregnant, that same provider hopefully could deliver their baby. We are in a bit of a provider. We only have one provider right now that's doing births at Maple City, or attending deliveries, I should say. And anyway, and then also having the pediatric care in the same office afterward where they can come back and see the newborn provider as well. They can establish with a behavioral health person in our office that's integrated as well as a dietitian. And then we have navigators that help to complete that insurance piece or any financial assistance that might be needed. Let's see, affordable care. We don't turn anybody away based on their abilities to pay or have insurance. If you'd like to hear more about those things, I would direct you to our Director of Operations, Alita, who's in the building as well. The two things that I really wanted to highlight today are what we do for our prenatal care. So Maple City for many years has participated in, it's called Centering Healthcare Institute. And so we do centering pregnancy groups and centering parenting groups. They have a great website, the Centering Healthcare Institute. You can familiarize yourself with that. But it's a prenatal care model. So what it does is it replaces the office visit that is routine in pregnancy. So usually around the 20-week time frame, I call patients who are due within a month or two of each other, and I say something like, I'd like to invite you to participate in our pregnancy groups. They meet every other week from 4 to 6. Included in that group setting are other women who share your due date within a month or two, a provider, a nurse, and a medical assistant, and an interpreter. So if you would like to opt into that type of model of care, what that means is that you no longer come into the office for your visits, but you show up to this group. For the first half hour of the group, the provider is doing one-on-one assessments with the patient. We take their blood pressure, their weight, we measure their belly, listen to the heartbeat. All that's done in kind of like a semi-private area, and then the nurse kind of registers the patient, takes any questions or issues of note that may have arisen, and then we meet as a group. We share snacks together, healthy foods, we chat, and then for the last hour and a half, it's all participant-led. So the women are encouraged to bring any concerns, any questions that they have, the things that they're personally going through in that time, and we use the time to address those. Sorry. I'm also, my brain is like everywhere today because I am coming here I'm still on maternity leave. I have 5-month-old twin girls at home. And anyway, I'm a little bit scattered. So anyway, Jean-Marie, is that how you pronounce it? Yeah. You mentioned using like motivational interviewing and talk-back approach. I think both of those are really good communication tactics when you're trying to engage a patient and get them to like not be the one-size-fits-all, but to see them as an individual and hear their own experiences and the responses to those. Putting that in a group setting where the provider is coming with the same amount of leadership, really, as the participant, allows for, I think, even better dialogue between, and you can really get to the heart of some of these like interesting topics like safe sleep. You can hear exactly like what is your sleep arrangement and how can we make it safer, and and it's really beautiful in the group when like one participant says something and the other one says like, oh, I've tried this and this worked for me, and the provider doesn't even have to say that, or like, anyway, it's just really beautiful the way it ends up working. The other program that we do in Maple City is having the doulas. Okay, I'm getting the cut symbol, so I'll leave you with that.
Thank you, and I think we have two more members. One more. Yes. Wonderful.
Hi there. Good afternoon. My name is Katie, and I work for Women's Care Center. I am one of the teachers there and a registered ultrasound tech. We are so thankful for an event like this and to partner with different resources in the community in hopes to lower that infant mortality rate. We love to educate moms. I don't know if anyone knows about Women's Care Center, but we have 35 centers in the U.S., and it's all free. We're a nonprofit. All of our services are free. And the thing I love the most is our parenting classes, where the Hispanic community comes together. It's not just Hispanics, right? It's white moms, black moms as well. But it's so wonderful because the Hispanic community, especially if they don't know English, feel like they have a place to belong. And I teach the Mommy and Me music class. And I always tell my Hispanic mamas, I say, I'm going to learn Spanish with you and you're going to learn English with me. So we do both. But it's just partnering along with them and telling them they can do this on their own, especially in the summer, right, when they're bored with the kids out of school. We love to educate moms with free parenting classes. We have a breastfeeding class, music classes in both English and Spanish. And they earn coupons. So our store is not cash. Nothing is bought in cash. It's all with coupons. So every time they come to these classes, they get coupons and diapers. They can bring their father of the baby if he's available. If he's not, some of them, have maybe an absent father or a father that's in a different country or something. Then they can appoint a person like their mother or sister or friend to come and earn double the incentives. So again, from the time they walk into our facility at Women's Care Center, everything is free. So the pregnancy test is free. We do and we partner along with them and do free post-abortion counseling too, because it's so important for them to not sit in that shame as well, and to get that kind of help that they need. My favorite thing too is when they get enough coupons, we take them to the store. It's called our Crib Club. And again, there's no cash used, it's just the coupons. And when they order a crib or a car seat, we don't just say, here's your crib or your car seat. We make sure that they're educated, right? So that infant mortality rate is lowered. Safe sleep video, they have to watch that before they can go out the door with their crib or with like a pack and play. A car seat safety video, and I never really knew about it. I have 3 kids myself, but it's crazy how it can save your lives, right? Just having that buckle up where it's supposed to be instead of down. So we do the car seat safety tutorial instructions for them before they are even allowed to leave our center with the car seat or the bed. Like I said, all of our services are free. It's an incentive-based program. And the thing I love as well about women's care centers, we're not done with them once they have the baby. We offer them to come back for 5 years. So all the children can be up to 5. And then my daughter actually is our child care provider in Elkhart here. So she will watch her little ones once they're old enough to walk and come to the parenting classes, and you still can earn incentives. And you get education. Like I said, free pregnancy tests, free ultrasounds. And then also, we also help them to get an OB doctor because we're not a medical facility. So we like to, love on them, give them free services, but then also want to make sure they're in the care of a good OBGYN or midwife, okay? And then like I said, our classes that we have a walking class, we have a pregnancy class, parenting classes, breastfeeding class, strong fathers for the dads, and a Mommy and Me music class. So I would love to answer any questions for you afterwards. Feel free to ask about our programs at Women's Care Center. Thank you.
Hello, how is everybody? I see some familiar faces here, so that's exciting. My name is Arely Perez Pisaña, and I have the privilege to work closely with Liliana for many years and participate in one way or another with the Northern Indiana Health Coalition, so it's a privilege to be here. And this topic of infant mortality is one that I really enjoy. I've had experience working especially with women who are pregnant and have gestational diabetes, and worked in community health centers for about 20 years now. And so there are a couple of things as I was talking to Liliana and just participating in this study that resonated with me, and based on what I have experienced and the settings that I have worked with, that I would like to just talk about briefly. So the importance of co-production in healthcare, which means that patients and healthcare workers or providers work together to plan, provide, and review care. And it values the patient's personal experience and focuses on shared decisions and equal teamwork to improve health services. I have found that when we take patients' experience and we not only learn and gain knowledge from it, but we value it, that makes a huge difference. When we take the time to slow down and to actually comprehend what the patient or where the patient is coming from, that makes a huge difference. Another thing that came to my mind is switching our mindset and practices from providing culturally competent care to culturally safe care. And that is a huge difference. And just briefly, I would like to talk about those two things. Culturally competent care is limited because it focuses only on gaining knowledge, learning skills, and it doesn't support flexible care that adjusts to people's different cultures, right? Languages and social needs. So it's all about learning, gaining knowledge, but not really having flexibility. But creating a culturally safe care it's a concept that says that health care providers shouldn't just learn about different cultures, but they should think about power dynamics. They should think about or reflect on their own actions and letting the patients decide if they feel safe and respected. So that is a big job for all of us who provide healthcare. Making sure that we are aware of our own biases or of our own power dynamics. And when we come in contact with the patients that we serve, that we come knowing that they are experts in their own health, that they know how to take care of themselves in a way. I know we have gone to school, we have all this knowledge, but at the end of the day, making sure that we establish that relationship with our patients is key. And I feel that all that starts at the top. With our leaders, with the people that are leading our organizations, making sure that we are providing the proper training for staff, starting in the front office, making sure that people are aware of trauma-informed care. How do we receive people? What are the things that make people feel comfortable? Especially nowadays, you all know I don't need to tell you about our current world, but starting from how we receive people, how we greet them, making sure that those of you who are in positions of hiring people, that you're hiring good fits, not only people because you need more people, but making sure that all your team has the same values and operates with this in mind. So thank you.